Hey everyone, and welcome. Today we're going to dive deep into a really important topic in mental health, mood disorders. We're going to be using Chapter 6 of a short textbook of psychiatry as our guide to really unpack what these conditions are, what they actually feel like, and crucially, how they're diagnosed and managed.
Okay, so first things first, we need to get a critical distinction straight. In the clinical world, mood and affect are not the same thing at all. You can think of affects like the weather. It's that quick, fleeting emotional reaction you have to something specific. But mood is the climate. It's that long-term, sustained emotional state that kind of colors everything you experience. And this difference is absolutely key, because mood disorders, well, they're a problem with the entire climate, not just a single rainy day.
And just to give you an idea of the sheer scale we're talking about, a World Health Report from back in 2001 estimated that 121 million people around the globe were dealing with depression. That made it the fourth biggest cause of disability worldwide. Now, you can bet that number is a whole lot higher today, but it gives you a powerful baseline for just how huge this global health challenge really is.
So here's our game plan for this explainer. We're going to start by really stepping into the experience of mania and depression to get a feel for what they're actually like. Then, we'll look at how clinicians piece those experiences together to form diagnostic patterns. After that, we'll dig into the super complex web of causes, the why behind it all. And to finish up, we'll explore the paths to management and recovery, because, understanding is just the first step.
All right, let's get right to the heart of it all, the experience itself. At their core, mood disorders are defined by these two fundamental, almost polar opposite states of emotion, mania and depression.
At a high level, the contrast is, well, it's pretty stark. A manic episode is all about a mood that's way up, elevated, expansive, or sometimes really, really irritable, and it's paired with a massive surge in energy. A depressive episode, on the other hand, is defined by this deep, pervasive sadness and just a total loss of interest or pleasure in pretty much anything. And a manic mood isn't just one static feeling. It's often a progression, a spectrum, that can escalate pretty quickly. It might start with euphoria, which honestly feels amazing, but it can build to elation and then to exaltation, where these grandiose ideas start to creep in and you lose touch with reality a bit. And in the most extreme cases, it can become a state of pure ecstasy. This progression is so important to understand because it shows how something that starts out feeling positive can become incredibly dangerous and impairing.
So how does that internal feeling translate to what you'd see on the outside? The textbook has this perfect phrase for it: on the toe, on the go. It describes this thing called increased psychomotor activity. Basically, you're physically restless. You feel driven to be constantly moving. Speech gets super fast and pressured, and thoughts are racing so quickly they become a flight of ideas. And this is all being fueled by this hugely inflated self-esteem, a crazy reduced need for sleep, and often a total breakdown in judgment that leads to really high-risk stuff, like wild spending sprees or reckless business decisions.
Now, on the complete other side of the spectrum, you have the inner world of depression. It can often be boiled down to this really powerful and painful triad of thoughts. Hopelessness, this feeling that there's no hope for the future. Helplessness, the belief that no help is possible right now. And worthlessness, just this deep, gut-wrenching feeling of inadequacy and being less than. These three beliefs, they create a very real and very painful reality.
And this quote from the source it hits the nail on the head. It perfectly captures the key difference between clinical depression and just feeling sad. It's that persistent, unshakable nature, a mood that doesn't lift even if something good happens. It's like being completely walled off and disconnected from the world around you.
So a single episode is really just one piece of a much bigger puzzle. A clinical diagnosis of a mood disorder comes from understanding the pattern these episodes create over time. Let's dig into how those patterns build into specific conditions.
This visual is just a fantastic way to picture the wave of bipolar disorder. You can see the deep troughs of depression, the high peaks of mania, and right there in the middle, the baseline of a stable, normal mood, which clinically is called euthymia. The specific diagnosis really just depends on the unique pattern of these peaks and troughs someone experiences over time.
So, what's the key difference between the two main types? Well, it all comes down to the height of that peak. Bipolar I disorder means you've had at least one episode of full-blown severe mania. Bipolar II, on the other hand, involves episodes of hypomania, which is a less severe high that usually doesn't land you in the hospital, along with episodes of severe depression.
And what if there are no peaks? What if someone only experiences the troughs on that chart? Well, if an individual has repeated episodes of depression but has never had a manic or hypomanic episode, the diagnosis is recurrent depressive disorder. You might also hear it called unipolar depression.
But the picture also includes these chronic, less severe conditions. Dysthymia, for example, is a state of persistent low-grade depression that can last for years. And cyclothymia is a long-term pattern of cycling between mild depressive symptoms and mild elation, but they never quite meet the criteria for a full-blown episode.
And finally, this graph shows a really specific and challenging pattern called rapid cycling. This gets diagnosed when a person with bipolar disorder has 4 or more distinct mood episodes, in any combination, all within a single year. As you can see, it creates a much more frequent and rapid wave of mood shifts, which can be incredibly disruptive.
So that's the what. But what about the why? What actually causes these profound shifts in mood? Well, the textbook is super clear on this. There is no single simple answer. It's a really complex interplay of a whole bunch of different factors.
This chart gives us a great bird's-eye view. The causes are multifactorial. They stem from a combination of genetic vulnerability, the biochemistry of your brain, the impact of psychosocial stress, and even your patterns of thinking. It's truly a biopsychosocial puzzle.
Now let's zoom in on genetics, because this is pretty significant. This chart shows us what are called concordance rates in twins. Basically, the probability that if one twin has a disorder, the other will too. And these numbers, they're really telling. For bipolar disorder, if one identical twin has it, there's a 65% chance the other will. Compare that to just 20% for fraternal twins. We see a similar, really strong pattern for unipolar depression too. That huge gap between identical and fraternal twins points directly to a powerful genetic vulnerability.
Okay, on the biochemical side of things, one of the biggest theories for a long time has been the monoamine hypothesis. The basic idea is that mood disorders are related to some kind of issue with key chemical messengers in the brain. Neurotransmitters like serotonin, norepinephrine, and dopamine. Now, the early ideas of it just being too much or too little are seen as a bit too simple these days, but the way these systems function is still a huge area of research.
But here's the thing, biology isn't the whole story, not even close. The source makes it really clear that stressful life events often act as the trigger, the thing that precipitates the first episode or a relapse in someone who's already vulnerable. Our environment and our experiences play an absolutely crucial role.
This brings us to our final, and honestly, maybe the most important section, the path to management. Once a mood disorder is suspected, what does that journey toward treatment and recovery actually look like?
The very first step is a careful diagnosis, which is kind of like a process of elimination. First, clinicians have to rule out any organic causes, a medical condition or substance use that could be mimicking the symptoms. Then they have to differentiate it from other psychiatric conditions, and finally from things like a normal grief reaction. It's a really methodical process to make sure they land on the right diagnosis.
So after all that careful diagnostic work, what happens next? Well, treatment usually falls into 2 main categories, and they often work best when they're used together. First, you've got somatic treatments. Think of these as the biological approaches, the ones that target the physical and chemical workings of the brain. This includes pharmacotherapy, medications like antidepressants or mood stabilizers. Then, on the other side, you have psychosocial treatments. These focus on our thoughts, our behaviors, and our environment. This is where you find things like cognitive and behavioral therapies, which are incredibly effective for managing symptoms and building coping skills.
So, we've journeyed through the clinical features, the diagnostic patterns, the complex causes, and the different paths to treatment. But as we wrap this up, it is so important to bring it all back to the human element. Really understanding these conditions is the absolute first step towards empathy and effective support. So, I'll leave you with this question to think about. Knowing everything we've talked about now, what is the single most important thing to remember when you're trying to support someone you care about who's living with a mood disorder? Thanks for joining me.